Well, it is my very great honor to introduce a psychiatrist, mentor, colleague, Dr. Jan Fawcett, who is now, I don't know if he'll ever retire, but he's living in my what I consider now my hometown, Albuquerque, New Mexico, that I've been here now longer than any place else. And he has a home in Santa Fe, and he's on the faculty of the University of New Mexico, from which I graduated. If I were to tell you all the interesting things about Jan, he would have no time for his talk. So briefly to summate, he was trained at a whole bunch of interesting places, the Naval Academy in Annapolis, Rochester, Yale, where he went to medical school, internship at the U.S. Public Health Service in San Francisco, residency in psychiatry at Langley Porter in San Francisco, did a psych residency at Rochester Medical Center. Of course, he's board certified. He's a life fellow of the APA, which I might be in 2 more years. He has so many honors. He's been the top doc in every city he's lived in. He's the editor of about 7 or 8 magazines, psychiatric, peer-reviewed psychiatric literature. So I see his name everywhere. He's an expert in suicide, bipolar disorder. He's the chair of affective disorders in the DSM, the Diagnostic and Statistical Manual, which is the Bible, as you know, or the menu for psychiatric diagnoses. And it's also an annuity for the APA. Every 10 years you have to buy a new one, though this year it's been controversial and it's been put off probably till 2013. So there's hardly anything that Jan has not had his mind in, and I'm very pleased to welcome Dr. Jan Fawcett.
Good morning. It's wonderful to be here in Ogden. My wife Katie and I decided to make it into a road trip from Santa Fe instead of flying. And you know how flying is these days, how difficult it is to get through airports. And so it was such a relief to drive through the beautiful scenery and come up here. It did take a little longer than I thought. But on the way, the last airport trip I took, there was a Buddhist monk walking through in saffron robes. And he walked right past security, and they stopped him and said, "Sir, you have to present your identification." He reached in his back pocket, pulled out a mirror, looked at it. He says, "That's me, all right." I don't think we could get away with that. But well, today I've been asked to talk to you about bipolar disorder, and I know I'm talking to a general medical audience, and I was trying to decide what could I tell you that would be best in this area, and I think I'll just tell you the truth, that bipolar disorder is a moving target. What do I mean by that? I mean that its diagnosis is somewhat fluid based on the data that's been coming out in the last 10 years. The treatment notions are changing, and I'm going to try and give you some ideas about that in this talk. And go over that with you. And I'll be glad to entertain any questions you might have after or during, if it's a pressing question. I'll try and cover the things that I think are pertinent for your work in your practices. And if you have questions, don't hesitate to ask me. I've always, my background has mainly been in clinical research and clinical treatment. I've always practiced and seen patients as I came to Santa Fe to recover from a 30-year chairmanship in Chicago. And but I've always practiced, and I'm very interested in the clinician's dilemma of how to treat individual patients using data from gold standard studies that are really group studies and often artificially constructed. So I want to just start out and sort of back up, because even bipolar patients spend most of their time in depression. About 70% of the time ill or more, bipolar patients experience depression. And the occurrence of a major depressive disorder, I just want to go over some of the criteria, and I want to distinguish it from what is often in the general public misunderstood. If you go to a cocktail party and somebody tells you they're depressed because their stocks are down or been wiped out, of course that's not clinical depression. That's use of depression as an adjective, rather than the illness. And I call that demoralization for patients. I tell them that it's normal in human life when you try real hard and nothing works out. It's normal to feel depressed. And the difference is, of course, when things start working out for the individual, they feel better. Well, clinical depression, of course, doesn't work that way. And patients can have anything happen positive, and it won't really change their mood. I once had an accountant who was in a horrible depression, and I asked him, would anything make him feel better? How about winning the lottery? And without even smiling or any reaction, he said, well, he ran the numbers and decided it wouldn't help. So that's the difference between depression, the noun, the illness, and the adjective. So the first requirement to be in a major depression is for at least 2 weeks, and of course most patients have had this for weeks or months before they come into an office, that for the patient to have depressed mood and or loss of interest and pleasure in usual activities. Either one of those two symptoms are the entry symptoms. Plus, they have to have 5 or more of these symptoms during the same, and they have to be all present at the same time during the same 2-week period. If you'll notice, some of these symptoms are psychological symptoms, and some of them are more physical symptoms, such as weight loss or weight gain or sleep change. Fatigue is a very common complaint, of course, in depression. Diminished ability to think or concentrate. Whereas you can see other more psychological symptoms, as you can see in the list here. And a person should have 5 or more of those symptoms, with one of them being depressed mood or loss of interest and pleasure most every day for 2 weeks minimum. 2 weeks is an arbitrary period. Most patients have this much longer. There have been reported in European circles an entity called brief recurrent depression, where people will have very severe depressions that meet all these criteria and are often suicidal for a period of 2 or 3 days, and then it'll go away. And during that time, they may act on their impulses. We have not included that in our diagnostic categories. I don't think it'll make it in the DSM-5, which is due in 2013, because there's not enough published on it, enough data. But it probably would be under the NOS category, not under a specified category, if it were seen to be clinically relevant in a patient. Now, mania and hypomania, which are the cardinal symptoms of bipolar disorder, as well as appearing with depression, patients tend to vacillate back and forth, except in what I call a patient with mixed features, which I'll get to later. And here are the symptoms of mania or hypomania. The difference is severity, and to be a bipolar 1 mania, the patient has to be manic for at least 7 days, and have 3 or 4 of these symptoms that you can see in the list here. Patients that require hospitalization for mania, or patients who are psychotic, who develop delusions of being Jesus or some grandiose delusion. I had a patient once who was when back in the Iranian hostage situation, was sending amulets to people that he thought would get the hostages released, and he was also driving around in a limousine, warning restaurateurs that the mafia was coming to town. So, I mean, he was totally disorganized, but he had very grandiose delusions. That's a bipolar 1 situation. Hypomania only requires a 4-day duration. That may change. It wasn't based on data. It was done to not make the diagnosis of hypomania overly common, which isn't a good reason if nature doesn't show us that. We're going to test all that in field trials. But the symptoms are pretty much the same, except for the fact that in the new DSM-5, energy may be increased energy. Since bipolar disorder isn't just a mood disorder, bipolar folks, when they're in a hypomania or mania, have increased energy and activity. They get involved in all kinds of things, and that's a major component, and we may platform that a little, make that an entry criteria in the new DSM, as well as the mood change. Well, here's the mixed states. Now, mixed states have been sort of the joker in the deck of bipolar disorder, because for a long time we thought back in the lithium era, back in the 70s, we thought that people were either manic or depressed. But it turns out that between 40 and 50% of patients with bipolar disorder present with mixed features. That means they have elements of both dysphoria or depression and hypomania at the same time. What you see is a person who's very irritable, very active, but yet dysphoric. It's a negative experience. They're not euphoric. They don't make you laugh. In fact, they may kill you. They're very angry people. They're very impulsive. They're very agitated. And for many years they were diagnosed as paranoid schizophrenics because they often get somewhat suspicious of your motives. And so this is an area where the diagnosis has been difficult. As you know, psychiatrists have the interesting situation of not having any laboratory tests to guide them. We have to base everything we do on the information we can get from either the patient or from informants. And as you know how subjective that information can be. It can change. And so we rely a lot on on the patient's presentation to diagnose these disorders. And in mixed states, it can be very difficult. But you do see this tremendous hyperactivity. You see a person who's very depressed who works out every day for 3 hours. It just doesn't seem to fit. And there's always a lot of anxiety and agitation associated with the mixed states. Right now, in DSM-4, you have to have a full mania and a full depression to be diagnosed a mixed state. We know that, or a mixed state. We know that mixed features go across all levels of bipolar disorder, and even people with minor forms of bipolar disorder, like bipolar 2, or patients with even bipolar NOS, where the patient doesn't meet full criteria, but the clinician's convinced the patient has a bipolar disorder and treats them for it. You see mixed features. And so we are probably going to make that change in the DSM-5. I say probably because, as you know, in these group efforts, nothing's ever final till the thing is printed, because different votes can change things. Now, this bipolar hypomania that I'm just talking about, that doesn't exist officially right now, has been found by the NESARC study. Now, the NESARC study, that you wonder what the hell does that mean? The NESARC study is the National Epidemiological Survey on Alcohol and Related Conditions. Why is it called that? Because NIAAA, the Institute to Study Alcoholism, funded it. So they're studying alcohol problems, but they're studying all the other psychiatric diagnoses as well. And it's a face-to-face survey of 43,000 responders. It's a true epidemiologic study. As you know, epidemiologic studies are not subject to Bergson's bias. Bergson's bias is that if you study patients who are coming for treatment, they always have more disorders and more severe disorders than if you go out and find these people out in the community by random sampling. So you get a different picture of the prevalence and incidence of an illness when you do that. They came out with this, what they've called hypomania with dysphoria, and that's exactly what I'm talking about when I talk about mixed features. So they found a higher risk for dysthymic disorders, which is a chronic mild depression, anxiety disorders, and personality disorders than in patients in non-dysphoric hypomania. And they found more episodes of depression and hypomania. These people have a difficult prognosis and are difficult to treat. They found that 24% of these patients self-medicate with alcohol and drugs. It's higher with bipolar 1 patients, as you can see, 41%. So comorbid substance abuse is a real serious problem in bipolar disorder. Now, the epidemiology of bipolar disorder has changed over the years, and I'm showing that on this slide. The original prevalence, lifetime and 12-month prevalence, was 0.4%. That's based on an epidemiologic study, an earlier study. But in doing that, they recognize that they may be missing. As you know, in these epidemiologic studies, they're not done by clinicians. They train surveyors to go through a list of questions and go and knock on doors. There's just too many people to see it's just too expensive to send clinicians out to make these diagnoses in an epidemiologic sample. So they hire people, maybe college-trained or master degree people, to go out and ask a series of questions to the respondents. So these are fixed interviews. They're not a good interactive clinical interview. And so they realized at that time in 1997 they were missing, they may be missing less obvious cases. So they did replications and looked at this again, and by 2007 you can see the incidence has gone up to 1.1% for bipolar 1 disorder, 0.8% for bipolar 2, which was missed in the prior study. And then they talked about subthreshold bipolar disorder. In other words, they didn't meet the specific criteria at 2.4%. Well, what does that add up to? It adds up to about 4 to 5%. Now, that's a huge increase in incidence. Huge. And if it's true, it means that a lot of people are missing these diagnoses. So the real issue is the subthreshold issue. What is subthreshold? Well, it means that the patient doesn't have enough symptoms or enough symptoms for a long enough time to meet full criteria. Now, this may seem to you like how many angels can dance on the head of a pin when we start talking about that kind of thing. But remember, we're limited. We can't take a blood sample and get a blood bipolar level and make the diagnosis. We just don't have that technology to help us. We have no animal models, or very few animal models of mental illness to study in the lab, and so we have to look at these criteria and get the best data we can out of them. Well, more recently, the question has been raised whether major depression, what I'll call now unipolar depression, people who have recurrent pure depressions, may be on a spectrum with bipolar disorder. maybe some of these people with pure major depression have some subthreshold hypomanic features. And there's been a ton of literature come out in recent years, mainly from Europe, large studies, like 5,000 patients with major depression, and they look for hypomanic symptoms, such as crowded thoughts, increased activity, that kind of thing. And they're finding rates of up to 30 to 40% of patients with major depression presenting with subthreshold bipolar symptoms. Well, what does this mean? Well, there's a number of studies following these patients over 10 years and more and showing switch rates. They switch from being major depression diagnoses to bipolar diagnoses. And when we get to the discussion on treatment, which will come soon here in this presentation, you'll see what the significance of this might be. The patients with the bipolar features have a history of earlier onset. Early onset in the early teens early or late teens is always a poor prognostic factor because it means the patient's going to have more episodes, more drug abuse, more suicide attempts, and it's going to affect their lives more if they're not successfully treated. Recently, and you'll see this came out in 2010 in Nature Genetics, there's been a huge effort to get, since we know these illnesses run in families, they're highly familial. But the problem is that depression is more common, major depression is more common in the families of bipolar patients than bipolar illness is. But so there's this whole question about genetics. Are there genes to code in these illnesses? Well, I didn't put a slide up on this, but in the schizophrenia literature, there are 8 genes that have been found that are replicated across huge samples now of schizophrenic patients for schizophrenia. 4 of those genes also code for bipolar I disorder. Now, because the guys doing the genetics don't focus quite as much as they should on the clinical side, it hasn't been determined whether those were all patients with psychosis. Now, it could be there's genes for psychosis, but that hasn't been determined despite all the money that's spent on all these genetic studies. Recently, McMahon from NIMH has found an overlap between a gene using single nucleotide polymorph samples, SNPs, has found a highly significant association across both major depression and bipolar disorder. So what's happening in genetics is beginning to question whether all the illnesses we're diagnosing aren't on just a huge spectrum in terms of etiology. When we started talking about DSM-5 and what we could accomplish, we thought that because of all the genetic research and the imaging research, we can now measure these circuits using various techniques in brain and these illnesses. We thought we might, for the first time, be able to address validity of our diagnoses. Up till now, we've tried to go for reliability, that 2 clinicians would come up with the same diagnosis given the same criteria. We thought maybe we can address validity. And we got very excited and we reviewed the literature and we decided we were born about 20 or 30 years too early because the data just isn't there. It's so fragmentary, the findings so far, and they don't all agree with each other. So it looks like we're not going to be able to do that this time. Well, now McMahon comes up with a shared genetic susceptibility for both bipolar disorder and major depression. So the differences, when we look at whatever causative factors or etiological factors might be present, the differences and what we're describing clinically may be melting away somewhat when we get to the genes. Of course, what's thrown a wrench in genetics, the genetics people were quite confident that once they got the genome, we know the whole human genome, they were quite confident that they'd find genes causing these illnesses, and then we could find medications that turn these genes on or off, and that would be it. Well, how long has it been since the gene has been found for cystic fibrosis? Has it been 12, 15 years? Have you heard of a cure for cystic fibrosis yet? One gene, one single gene. We're talking about 8 to 12 genes that might be related in these affective disorders. So the genetic people have been a little bit, they've toned down their optimism a little bit as they found how complex this really is. And then the question of epigenetics has come in. Epigenetics is the effect of environment on the expression of genes. So if you take a bunch of wild-type mice or rats that you'd use for laboratory experiments, they carry a whole host of bacteria and viruses in the wild that they carry in the lab. If you wipe all those out with antibiotics, you get totally different response characteristics in these animals. Totally different genes come into play. That's called epigenetics. So if you add epigenetics to the genetic research, you're going to get so many different variants that it becomes a huge mathematical problem to get correlations. So this genetic overlap, I think, is a harbinger of what we're seeing more and more in trying to find the etiologies of these conditions that are so common and so devastating. Now, how often do you see bipolar patients in practice? Now, these are mostly psychiatric diagnoses, but not entirely. What Mark Olson did was to look at two huge databases. One was called MarketScan. This covered people who were privately insured and covered both total visits and unduplicated visits. Unduplicated would be the patient's first visit at least. And then he looked at a Medicaid database, and he looked at the same thing. And for bipolar disorder, the Medicaid, of course, is has different characteristics than the privately insured database in the patients. They're probably higher income, higher education than the Medicaid database. But so he looked at both, and he found in the unduplicated patients, 7.5% were diagnosed with bipolar disorder. Now, I told you the last epidemiologic survey was showing maybe up to 4 or 5% when you take all the milder forms into consideration. Bipolar 1 alone was 4.6% as compared to an epidemiologic finding of a 1.1% prevalence. Medicaid, it was 18.5% of patients seen once were diagnosed with bipolar disorder. 12.5% of them were bipolar 1, the most severe form. So this is a huge portion of practice. Then the bipolar NOS category, which doesn't require really anything except for the clinician to highly suspect that the patient is disabled or distressed by bipolar disorder, we found that 19 to 25% of the diagnoses are in this area. So this makes the bipolar disorder a huge part of the diagnoses that are being made and treated. The patients are being treated. Now, on the other hand, there are people who feel that bipolar disorder is underdiagnosed. And he presents a study here of a clinic where they found that 25% of the patients diagnosed with major depression actually had bipolar depression in an outpatient community clinic. So the whole issue is what are the true bipolars? Will they please stand up? In other words, this is a moving target. The diagnosis itself is a moving target. And it's important to make this diagnosis because of the treatment implications, which I'll get to. Why does it matter? Well, the diagnosis of bipolar disorder requires, to treat a patient with bipolar disorder safely and get a clinical result, it requires that the patient be mood stabilized. If the patient isn't mood stabilized and just given antidepressants for their depression, it can make their illness worse. It can lead to suicide attempts. It can lead to all kinds of horrible outcomes. So it's very important that, and there's evidence which I'll show you that's coming out of some studies of bipolar patients, that antidepressants may not work very well in bipolar depression. There's another problem that's on the horizon. That's another moving target. The treatment of bipolar disorder is also in flux. So, but if you treat these people, you use medications that have side effects that are not inconsequential. So it's an important decision, and you can there's complications of treatment, including secondary diabetes, tardive dyskinesia, neuroleptic malignant syndrome. Can happen even from the newer antipsychotic medications. So you've got a real problem here. In the pediatric field, many of you may have read the New Yorker article. I mean, there's been a lot in the press about the overdiagnosis of bipolar disorder in children. What does this lead to if it's overdiagnosed? It leads to the use of very powerful medications in kids. They're presumably going to be taking these meds for the rest of their lives. If you're incorrect in your diagnosis, think of the issues here. On the other hand, investigators like Robert Post have talked about child bipolar disorder as what he calls the perfect storm. Because if children are undiagnosed with bipolar disorder, their condition will plummet. They will have problems in school. They will have problems with drug abuse. They will usually end up not making it through school. They'll have suicide attempts. They'll have a life that by the time they're in their late teens, they're more or less ejected from society, from a normal development. No matter how bright they are, they could be geniuses, and it can still happen. So making this diagnosis is really important. And there's a study by Moreno which has shown an increase in the diagnosis of child bipolar disorder in the United States of 400%, with no corresponding increase in Europe. So it's a huge issue. And I've got TDD down there. This will probably change, but we are so desperate to do something about this that we have come up, there's another condition that's been found called temper dysregulation and dysphoria right now disorder, TDD, in children. And what is this? This is a child who's very negative, irritable, angry, chronically, and has temper tantrums, huge temper tantrums, at least 3 times a week. Now, irritability is the most promiscuous symptom in psychiatry. It goes across all kinds of different disorders. And these kids are highly irritable and angry. There's only one study that's been done following these kids into adolescence, and they end up not developing bipolar disorder, but developing major depression. So we're thinking of introducing a diagnosis. It probably won't be called TDD because nobody likes the name, but based on a single study, because we're so concerned that clinicians have another alternative to diagnose these kids, these difficult kids, other than bipolar disorder. The question is, what's the treatment for TDD? And that's not so clear. But they do develop depression and anxiety disorders when they become young adults. On the other hand, underdiagnosis, I told you, may lead to poor response to antidepressant medications, temporary improvement followed by mixed features, and relapse. So what I'm trying to do is present to you the crisis, sort of, that's involved in this differentiation. So, when is a patient bipolar? How many symptoms does it take, and what duration? Can we determine this? And so we are talking here about a borderland issue between the two conditions. Here's a study of patients with who showed these borderland symptoms, and you can see that suicidal ideation was associated. Here's some of the symptoms in major depression that correlate with later bipolar disorder. And you can see here that in the bottom of the slide that irritability was much higher in this depressive mixed state. DMX is depressive mixed state. Racing crowded thoughts, 89% versus 45%. Psychomotor agitation, 51% versus 4%. So you can see that this borderland problem is major. And when we talk about suicide at lunch, you've heard about the problems with the black box on antidepressant medications, SSRIs. The FDA has said that they cause more suicidality in children. It's not suicide. There's been no increased reports of suicide, as I'll tell you. But one of the problems is if you give a child or a young person an SSRI and they really have bipolar disorder, it may be one of the causes of the agitation and increased suicidality, which are increased threats and gestures and behaviors that are seen in kids. So, we are thinking of adding a mixed specifier to major depression. So if you see a patient with major depression, I've listed all the papers in the small print here just to show you how much evidence has come out on this, both earlier and later and more recently. And we're thinking of adding a mixed specifier to major depression so the clinician can register this and watch these patients for later switching into bipolar disorder. Now I want to say some things about the treatment of bipolar disorder. The axiom is if you don't have mood stability, you've got nothing in a bipolar patient. So if you see a bipolar patient who's depressed and you don't get the history and you treat them with antidepressants, what you will frequently see is a short-term improvement and then relapse. A short-term improvement on the next treatment, then relapse. And then you'll see some increased cycling of mood. And you'll see that you have a problem. So there's a tremendous range from very severe and obvious to things that are more subtle. Lots of comorbidity with anxiety, severity, and substance abuse in these people. Well, when you are treating patients with mood stabilizers, one interesting thing, especially if you're using atypical antipsychotics, is a question of weight gain and the development of secondary diabetes. Now, Dr. Ravens, who's an endocrinologist at Stanford, who invented the term metabolic syndrome, would probably be very unhappy to hear me calling it Raven's rule, but that's how I remember it. Raven's rule is to divide the triglyceride level by the HDLs, and if you get a ratio of over 3, you're looking at insulin resistance development. You're not diabetic yet, but you're moving in that direction. If you're over 5, you're frankly diabetic. And he did this using a glucose clamp and laboratory animals. I like to use that rule when I watch my patients on these medications. Very simple little calculation. So you've got atypicals like olanzapine or Zyprexa showing huge weight gain, very likely weight gain, and a high percent. And you have, in order to follow them, you've got to follow their glucose and hemoglobin A1C. That's not, there's a typo on the slide there. Triglycerides and cholesterol. Quetiapine or Seroquel. Seroquel's been approved now as an antidepressant for bipolar patients. It's got the strongest data of any antidepressant in bipolar disorder, highest effect sizes. But you do see weight gain and metabolic syndrome in patients with quetiapine. They have to be followed closely. Divalproex, Depakote, the anticonvulsant. You've got the PCOS syndrome in young females with irregular menstruation and weight gain and masculinization. With Risperidone, you have moderate weight gain. Lithium, you have moderate weight gain. So all the treatments we have for bipolar disorder have to be monitored. The patient has to be monitored for these problems. In lithium patients, lithium is one of the few drugs in bipolar patients that often works by itself. If a patient is a lithium responder, they usually don't need anything else. Whereas, as you'll see later on a slide, in the STEP BD study at Harvard, at Mass General, 4,000 bipolar patients, 73% of them were on 2 to 3 medications just to get mood stability. That's how effective our medications really are. More issues with mood stabilizers. You can get extrapyramidal syndromes. You can get tardive dyskinesia with the new atypical medications. I had a patient develop tardive dyskinesia chewing, automatic chewing, on 200 milligrams of Seroquel for about 6 weeks. And she was it worked beautifully for her. She had been a lithium responder until she had a thyroidectomy and no longer responded to lithium after that thyroidectomy. The other medications, you see the same thing. You see EPS and dyskinesias. These are all complications of these medications. You can also get Stevens-Johnson's rashes with lamotrigine, especially with too rapid dose escalation. And with the carbamazepine and oxcarbazepine, you can get the same thing. It's less common. I haven't seen a case. I've seen cases with lamotrigine, but not with these other drugs, but they certainly can happen. Other issues with mood stabilizers are in young fertile females. Divalproex can cause, if they become pregnant, can cause neural tube defects. And of course, by the time they come in and tell you they're pregnant, it's too late. Carbamazepine's a problem with that. I love carbamazepine in mixed patients, but in a fertile female, if they are taking birth control, carbamazepine accelerates the metabolism of every drug the patient takes, including birth control pills, and so the birth control pills may not work if they're taking carbamazepine. Lamotrigine has been used, and so far there's been no reports of hazard in pregnancy, in contradistinction to the others, which can cause serious neural tube defects. Lithium was originally thought to cause a high rate of cardiac defects. That estimate is dropped with subsequent studies, but it's still possible. Now, mood stabilizers can have other positive effects. Anxiety is one of the most severe negative predictors of outcome in bipolar disorder, and it has not been fully recognized till more recently. If you take a patient's anxiety level on a single scale, and follow them for 20 years, which has been done, this more severe anxiety they have will predict the amount of depression they have, the amount of weeks they're in depression over the next 16 to 20 years. So anxiety turns out to be, both in major depression, but especially in bipolar depression, a predictor of a poor outcome. Well, olanzapine, quetiapine are highly anxiolytic. That's an advantage. Ziprasidone, Geodon is moderately anxiolytic. So these medications have the benefit of reducing anxiety in these patients, which up till recently has been fairly much ignored. The assumption has been that it'll go away if the patient gets a good response. Now, lithium, which was the first drug, and it really put bipolar disorder on the map. I gave lithium in 1964 at the National Institute of Mental Health. It was approved in this country in 1970. It was discovered in 1955 and used in Europe before it came to the United States. When we got lithium, we started diagnosing bipolar disorder. It was interesting. These patients had been diagnosed with schizophrenia. They were more severe. They had psychoses sometimes, and they were diagnosed as schizophrenics until we found out that especially euphoric mania responds, traditional mania, which is what we thought it was in the beginning. We didn't know about mixed states, although they were described by Kraepelin in 1920 when he described manic depressive illness. We now know that lithium doesn't work too well in mixed states, but it works in euphoric mania in many patients. Lithium has been reported, especially from Europe, to have anti-suicide effects. Why would that be? Even at low therapeutic levels, even when it is not fully effective in controlling the affective disorder. And as you'll hear, if you hear my lecture at noon, one of the traits associated with suicide is impulsivity. And impulsivity may be regulated by lithium and its effect on the serotonin system in brain. For mixed features, divalproex, carbamazepine, divalproex is Depakote, Tegretol are most helpful, as well as the atypical antipsychotics. Well, here's another just business on following up patients on all the anti-manic medications. Well, I told you this in the STEP-BD study. That was the name of the study. Sequence treatment enhancement procedures for bipolar disorder. 70% of patients were on 2 to 3 medications. There is literature showing that bipolar 2 or milder manic patients require lower doses than the more severe forms. And comorbidity may increase the need for higher doses of medications. Now, what about bipolar depression? I made some hints about that earlier. Bipolar patients spend most of their time on depression. Is depression in bipolars the same as it is in unipolars? Well, people have been acting as if that's true, but there are very little studies showing response of bipolar patients to antidepressants. The studies that have been done have been negative. And so what we're seeing is that studies of antidepressants in bipolar depression are showing that they're not effective. This study from the STEP-BD study was published in the New England Journal in 2007, and it compared paroxetine and Wellbutrin, Paxil and Wellbutrin, with placebo added to a mood stabilizer in depressed bipolar patients. And you can see that the placebo did better than the antidepressant drugs over 6 months. This is a serious blow to our concept of treating depression and bipolar disorder, just putting them on an antidepressant. And we are going to have to deal with this by coming up with other treatments for bipolar disorder. Right now, leaving them on the mood stabilizers seems like the best idea, but some patients get so depressed and suicidal that you have to do something, and that's the issue. There are contradictory opinions in the literature as to whether antidepressants even work in bipolar disorder right now. That's a moving scene. We don't have the conclusions yet. So, we can see that bipolar disorder may be expanding into a spectrum merging with unipolar major depression. And this is important because there may be different treatment responses between the two forms. Mood stabilization is the most important thing you can do for a bipolar patient. But most people see the patient depressed and put them on antidepressants. So there's some dilemmas that have come up in this disorder, and I don't have all the answers. There are other treatments for bipolar depression. Seroquel is one. Mirapex is another that's been used to treat Parkinson's disease, may work in bipolar depression and may work in unipolar depression. So I'll stop there. Thanks. Oh, wait, I'm sorry. He's giving the mic to the guy behind you. He'll pass it to you next.
Doesn't see.
You got it?
Is this working?
Yeah.
Okay. Is there any neat line between mania and hypomania?
Between what?
Well, you talk about mania and hypomania as if they were two distinct conditions, and I'm wondering if there is a nice clean line between them.
Well, there's a couple studies showing that they breed true in families, that families with hypomania tend to have other relatives with hypomania versus mania. But in other patients with full mania may only show hypomania at certain times in their course. So you really have to follow the patient over their entire course to know that answer. So you may see hypomania in bipolar 1 patients at times, and then full mania another time. But most hypomanic patients don't develop full-blown mania. If you put them on an antidepressant and they cycle, they don't go mad and do kinds of things like bipolar 1 patients can do when they get manic.
I'm old enough to know about electroshock. Whatever happened to that? Is that still effective?
Electroshock will terminate mania. It's used as a last resort. The use of electroshock has been mainly suppressed by its cost. It was once thought to be a very bad, punishing treatment. Now, the way it's given now, the patient's given anesthesia, and the patient doesn't even know they've had a seizure if it's done correctly. And it can be very effective in terminating a very serious condition like a psychotic depression or a mania that's not responsive to medications. The problem with it is the relapse rate. You haven't solved mood disorders are a lifelong problem. They're like hypertension, except with much more severe symptoms to the patient at the time, and they can make the patient unable to function. So when you get a person out of their depression, that's not the end of the story for many patients, and especially for bipolar patients. It's a lifelong diagnosis. The rate of switching into mania or depression is as high when you're 80 as it was when you're 20. That's been verified.
I was just wondering, we have a lot of people that end up in the emergency room with suicide attempts,
right,
and then they are not even kept overnight oftentimes, and they just to follow up with their primary care physician. Is there any combination of medications that work quickly? Because as we all know, there is nothing that works quickly.
Well, I'm going to address that at noon if you're going to be there. I'm going to talk about suicide, and I'll mention that. Let me just say that, which I'll tell you then, that the ratio of suicide attempts to suicides, nobody looks at that much, but the national ratio is about 26. One suicide for every 26 attempts, and it may be higher than that, maybe 1 for 30, because a lot of attempts aren't reported. It's 3 for bipolar disorder, 1 suicide for every 3 attempts. So we're talking, once you diagnose, the importance of diagnosis is you talk about the increased risk of death.
I'm sorry, can I do one more quick little questions about these antipsychotic drugs and all the multiple side effects? Do you think it's wise to have them sign a slip like we do with the acne medication?
Yes.
Is
yes,
there a
I do. I
standardized
think they
script
should
for
be
that?
told. They can.
Yeah,
They can.
so definitely tell them, but I'm just wondering liability-wise if we have to do the same.
Well,
with
that's
Accutane.
becoming standard of care.
Okay.
I just received my. I have part-time insurance because even though I'm covered at the University of New Mexico, I do some. I see a few patients outside of that. And this year they asked me, do you routinely give your patients a form with all the side effects giving you permission to give them this drug? It was on the insurance company application this year. Okay.
Do you have any symptom complex that you have that you think a patient's beginning to cycle?
Well, it varies. The best way to figure that out is to ask their spouse, because the spouse always knows when it's coming. And there is some individual differences, but usually the major factors are increased energy, less need for sleep, interest in making phone calls to people, increased irritability. Those are the common things that you see when the person's starting to cycle.
My wife diagnoses it very well.
As we kind of go back and forth in society trying to understand what is bipolar, what is depression, and to some extent we're arguing about genetics, pathophysiology, but to some extent we're also understanding the role of society as a causal agent in psychiatric illnesses.
Mm-hmm.
At what point do we start looking at social context as the problem as opposed to biology?
Well, we do look at social context, but some of the illnesses appear to be much more biologically driven, such as bipolar disorder. In twin studies, for instance, there's a very high concordance between identical twins. If one has bipolar disorder, the other is much more likely to, it's about 70% likely to have it. There are exceptions, but so we do look at, and there certainly are precipitating factors and social factors. Also, social factors are much harder to address. I mean, how do we address the fact that our society's gone from being one that believes in self-reliance and responsibility to becoming a materialist, narcissistic, acquisitive society where it's me, me, me? Well, how do we address that as physicians? How do I address it as a physician?
That's my question.
Yes. And the context we're in is very hard. I think the only way you can address that is as a politician, and we're not getting much guidance from them, that's for sure.
And those of you that were fortunate enough to be here yesterday, we had a 3-hour discussion, a panel with conservatives and liberals addressing those very questions, and they were lawyers and policymakers, not physicians. And I certainly think that there is a big mush in the diagnosis of bipolar disorder, and now with pharmaceuticals and whether it's personal responsibility, you know, I had a line when I lecture on bipolar, and I still don't know what it is because the committee, as you said, is a moving target every 10 or 20 years, and on that day they make the decision. But you know, sometimes I say to patients, they'll tell me about their husband or their son and how terrible and irresponsible and then moody, and they say, what can you do, doctor? Like all of a sudden it's my responsibility to fix them up. And I say, well, you know, what your son, what your husband needs doesn't come in a bottle. It's called character and maturity. which is kind of what we used to have. And someone else said, if everyone says, give me, who's giving them after a while? I mean, I'm still a liberal, but to the have and the have-nots that was in our local paper, who's going to be the haves anymore? So.
You're not a liberal who's been mugged, are you?
No.
That's a conservative.
Right. I'm still a mixture with a compassionate heart. So thank you very much, Dr. Fawcett. I look forward to hearing your lunch talk.